Let me just introduce our speakers. So I'm Chi Lee. This is Don Woodlock. That's Alex MacLeod. All right, that's quick.
Great introduction.
Yeah. I assume by now you know pretty much all of us. And so I just want to use this slide because this pretty much just summarizes what we're doing. This is from this morning when Paul talked about experiment. What we did was experiment. All right, just to be very clear about it, this is not something you can buy, but it's important for us to experiment. This, when experiment, whether it works or not, we're still focusing on the experiment aspects of it. We need to collect evidence to prove it works and so on and so forth. The second bullet point from Paul's presentation is also great. Find something that's value to the user and organizations. These projects came to us because health systems say, we have this pain point. They go at this problem for 3 times. The third time, they're like, okay, InterSystems, you guys are here already in our organization. Could you guys help? And it was so important to them that they said, well, I need help. So this is very important. That's why we need to stay close to our customers. Sometimes you always think that we're trying to sell you something. Not necessarily. Sometimes we just love hearing about your problems. And this is very important for us. And we know that there's a reason that we're engaged at this project. The third bullet is also very critical. Focus on data and the model. We deal tons of issues about the data and the model, and you'll see a lot of detail of that. And rethink deployment, support, and governance. This is also something that we run into as well. It's just a fantastic learning for us, for the organization, and of course, there's also the ethical behaviors and so on and so forth as well. So I feel like this was a wonderful slide that summarizes what we're doing. So, yeah, come to the front. Excellent. Yeah, no worries. Yeah. Looks like we should move this to a larger room. Yeah, yeah. Joining, definitely. This is a slide from last year. There was a clinician in Boston, and he talked about hospital AI and quite a bit. And what's interesting about this, he talked about these hospital AI domains and example use cases. We always say, okay, AI, okay, there's a technology, but what are the use cases? Now, what I want you to focus on is this particular part, position on technology adoption curve, which means that there are different stages. In this case, there are developing the solution, there's piloting, scaling, adopting, and mature. So this is very important. You look at, okay, there are great things that can help the clinicians and everybody and so on and so forth, but look at the 2 items there in the scaling state, right? Now, by the way, this is from a report from the economics. I forgot what MBER stands for, but economics of AI conferences. And so these 2 categories are the ones that are showing in the state of a scaling. People are adopting it, and what are they? The first is reimbursement. You got to care about the money. If it's not going to impact my top line, bottom line, why should I do that, right? It makes a lot of sense. So there's a coding, denial and management, and optimizing payments. So that's a very important area. And this is also what we're looking at. We should do some project in this area. Of course, we're going to help the clinicians and burnout and so on and so forth, but we also need to cover these areas. The second part is around what they call the corporate function, manage back office administrative functions. And this is also very important in a way that this is a lot of efficiency could come in, and where you can actually be a lot more productive in this case. So I want to talk about we have 2 use cases I want to talk about. So I will set up the first use case, the background, and so on and so forth. And Don is going to really go deep into the AI aspects. It's a fascinating journey. And of course, we have another use case, which Alex will cover as well, which is a new one that we're working on. And on day 1, you heard from Dr. Lin about the patient portal messages. Dr. Lin is amazing. Actually, I went to AMIA conferences, and that was the first time I heard him talk about patient portal messages. And that was a couple years ago. And it was just fascinating. So this is just a recap of things that people are how they are dealing with this. So in the Cleveland Clinic, they started charging patients sending messages between $35 to $50 because it costs the clinician time to do it, to properly respond, review, and respond, right? In UC San Diego, before COVID, during COVID, after COVID, during COVID, it tripled monthly messages. That's just how the volume is. You see that curve, you're like, okay, what does it mean, right? But in one of the examples that Dr. Ling mentioned, he didn't tell you that some of the physicians, they have 5,000 messages in the inbox. It's just fascinating how much volume there is, right? And also, there is a study looking at, I think it was 366 hospitals. It was conducted by an organization that looks at how much time did a clinician actually spend for each message, about 2.32 minutes, basically. So think about the volume, think about the time you spend, and it just adds up. So what happened is, of course, there's a documented papers about physician well-being is tied to the in-basket messages. In-basket is the EHR term for those inbox messages. It's generated by algorithm in the EHR. What that study talks about is looking at not just patient messages, but also system-generated EHR messages. What they found is that there's half of those messages generated by the system. Oh, patient has abnormal report. Remember the alert fatigue this morning you guys heard about? It also is reflected inbox message as well. So about 12% were from the patient. So when we look at all of this, there are a lot of messages basically hitting the physicians and the practices. So what can we do about that, right? What's also interesting, you heard before, you probably seen this report that was done, a study looks at machines are actually, in terms of, they're more empathetic, their responses is just beautiful. And you all probably also saw examples, earlier presentations about how the machine can generate a response to a patient request, acknowledge everything and just making meaningful suggestions where appropriate, sometimes make up things, but it does make the patient feel good, because it's very empathetic. So I want to jump into this particular project, Bay State Health. There's a reason they are one of the Impact Award recipients, because they work very closely with us and try to solve these problems together. This is very important. They're not just trying to say, okay, this product works or something, but rather it's actually they're working with us. It's a health system, has about 5 hospitals, over 1,000 beds in the Western Massachusetts. Very important area. Everybody thinks Boston. No, there's a big part of Western Mass that needs a lot of healthcare, and they're the one that doing all of that. Very important. Now, they get a lot of messages. So usually the patient portal message comes in, there is a triage process to determine if the message is urgent. And usually it's defined as a clinically urgent. So that's very important. The urgent patient just need a lot of maybe immediate services, assistance, but the criteria we're using here is clinically urgent. That also is very, very important when it comes to the AI part. Now, when we determine the urgent aspects of it, and I notice a timer has not started, doesn't mean that I still have 45 minutes though. So there is a 911 level urgent, which means that you're bleeding, something's broken, you need to call the ambulance right now, and you need to be taken care of right away. The second part is a warm transfer. I need to contact the patient usually within a few hours, but definitely on the same day, right? And so there's a list of the symptoms and what patient can experience that qualify for that criteria. So we basically look at the patient messages, about 1,000 messages a day, and actually increased over time, of course, and try to determine if there is a clinical urgency associated with these messages. How do we do that? By starting, just like any machine learning project, to manually label them. So we had a clinical team, and we look at these sample messages together, about 1,000 of them. We had a lot of fun actually doing that, and just say, oh, that's what it is. But we label those 1,000 messages. One of them is actually very urgent, and I'll show you an example. 35 of them are clinically urgent, and the rest are marked as not urgent. So we had to do the labeling, the data. So this gets to the training data aspects of it. How can you provide a training data so we can do AI work? And that's not easy. Now, this is the actual urgent message. We got a permission. It's de-identified, and really, patient has a lot of symptoms. And just even though the patient's saying that, well, it didn't seem critical, but the following symptoms, pain along the jawline, the pain along the side of my neck, and feeling the tightness on my chest. It just like, boy, this is sounds very serious. And it was actually one of the real cases, for them. And so when we did a retrospective analysis of the data, this is the one that we labeled, and it's also something that happened before. So it is true, it is real. So we built out the model, and so we will, certainly Don will go a little bit further detail. In the last year, we presented briefly about the early work in this area. And we used BERT and BioBERT, which was trained on the medical records, on the MIMIC data set, and also we add additional enhancements to it, BioBERT plus 21, that was the latest that we used before, and the AUC was about 0.93. And it's very difficult to get to 1, because it's a clinical urgent is difficult matter. It's not a black and white matter, so it's just something that the different clinicians have different criteria, and therefore it could never approach 1. So then there's a question about when do we think it's good enough to use, right? So one thing I learned from other people doing similar work, it turns out many other organizations have the same challenge. Guess what? They also are doing AI work in this area as well. So we did additional, a kind of a comparison. This is about 100 messages, 50 of those are urgent, 50 of those are not urgent. We got 3 clinicians. They are very blurry, and because they are real ones. And but what we end up doing is that we want to do the percentage agreement between the 2 reviewers. And in this case, A, B, C, D represent either machine or human. Can you tell which one is the machine? You probably cannot, right? It turns out D is the machine. So what the key point there is that we're saying that. In this case, it's very comparable in a way that there's agreement between the 2 clinicians versus the agreement between the machine and the human. So among human is 69%, with the machine average is 71%. I don't know how to interpret this. It's probably a margin of error. Doesn't mean that machine will agree with you more, but it's a good thing that we can say by adding the clinician or by adding the machine, it's almost like adding another staff that can help you to review this. This is one way to define, is that good enough? So that's an important lesson. I feel like that's a very good tip. Now, the production deployment is also very interesting. So we had a lot of debates. So this is something that you'll see other organizations like NYU in New York, they talk about the same challenge. If we put the word urgent, there's a sort of a legal liability in a way. The machine thinks it's urgent. What if a human look at this urgent? If this is urgent, I should do it right away. Why should I defer if it's not urgent? So when we decided in the end for pilot, this is also a lot of discussion with the hospital, say, we're just going to put an asterisk in front of the subject line, which is what you're seeing here. Their portal message starts with subject, my health. Now we put an asterisk in front of it. So it's very subtle, right? So it doesn't say the word urgent, but for practice, they're using it, they can sort. I'm so glad the sorting worked because the symbol, like asterisk, goes to the top. It's not in the middle. And it's unlikely they have other symbols. So this is something immediately go to the top. So we selected 3 pilot practices. They helped us. They say, well, these 3 are the ones that have a lot of patient messages. Let's start with those 3 before we go on to the next 12. And also appointment messages. This is also another area. Their practice leaders saying that appointment requests, when you have something you want to request appointment, there's actually a lot of clinically urgent stuff too. So why don't we also apply this algorithm on these appointment messages as well? Now, a couple of early results. So we found that it reduced the read time after messages arrives. It's very important that their standard service level agreement, this is no opinion or anything. Many hospitals are doing that. The service level agreement with patient portal messages, we will respond in 72 hours. okay, within 72 hours. You can also interpret it as, okay, they're not going to look at it on day 1, day 2, they will look at it on day 3. So our goal is that if we can put this flag or this asterisk, you can take care of the patient who have clinical urgent issues on the same day. That's really the reduction in time. It doesn't add more of a workload to you. It's more of a prioritizing. It's more of a triaging function for you. We also select the threshold to flag 6% with messages with the asterisk, and which is about 30% false positive. This is also interesting. Later on, Don will speak more into it about as well. When we are looking at the results, should we adjust the threshold? This is also another very important thing to discuss, and just so that people understand what AI can do. It has implications. And another instruction for the staff is you can remove the asterisk if the message is false positive. But that was very interesting. So people are reluctant to do that because the staff would say if the AI machine thinks it's a asterisk, if I disagree with it, am I allowed to disagree with it? What does that mean? For liabilities and so on and so forth. And so it was also very interesting when we initially think about what you should do. Because on our side, it means that now we are getting labeled results as the messages come in. If they say this is a false positive, that means, this will be used for future model fine-tuning, right? But on the workflow side, it's not so easy. I just want to emphasize it was a very long process for approval. This gets to Paul's other point about workflow, governance, but I would say that there was a lot of committee we had to go through. Technical committee, operational committee, clinical committee. We talk about all the potential 3 different ways of a large language model could help. For example, summarize messages in 2 words. It works beautifully, but they're like, well, let's not do that yet. How about auto response, right? Create a response message automatically in the clinical leadership. We're not quite ready yet because if it's generated by the machine, we had to put disclaimers and so on and so forth. We're not ready to do that. How does it mean by the customer service? They feel like, you're using machine to look at what I'm writing to you, And there's all these concerns people have. Another important thing is with the staff, because this is the practice staff, frontline, dealing with the patient, communications, we spend a good amount of time to develop a communication plan and a training material, just so that people say, wow, there's a new thing. What is it about? And how is it going to change my work? And all these are very important just so that internal team, not just the leaders, people on the front line understand what this is doing to their workflow. It could be very minor. We're just adding asterisk. But we need to educate them and communicate them. Don actually spent a lot of time explaining to them what is AI, and it was fascinating. I'm so glad that the hospital was willing to listen, and they are very supportive. Everybody was very encouraging and supportive in the learning, right? So, but it is still an IT project. We had to go through the standard process from the testing to production. Lots of these are coordinated with other activities, and so the deployment aspects, it needs a lot of coordination in the communication, So the last point was the confusion aspects of around whether to remove the asterisk. So we've been collecting data. So for this one, I'll just say in the first month, there are about 33,000 messages total. About 7,000 of those were reviewed by the AI engine. For the appointment requests and the pilot practices. As expected, 6.5% were marked as urgent. And the survey results, the practice leader also surveyed their frontline staff as well. Did you find it useful? What is the impact that you actually are seeing on your workload or your workflow, your way of dealing patients? Sometimes it could be quantitative, but a lot of times it's qualitative. So one specific example was, okay, have you seen a lot of false positives? People are like, you know what? We actually did not see a lot of false positives because some of these are borderline because I need to take care of those patients anyway, even if you don't put an asterisk on it. But it serves, even if you do, that it's not like even when you put an asterisk on it, I don't think it's a right away, but it is still relatively important. So that's the type of feedback that we're getting. But also very interesting is that the last bullet point, every week or every 2 weeks, we review the sample messages. We look at the messages based on sorted risk scores, the urgency prediction scores, and we find those are there in the borderline, or the high ones or at the borderline to see that if we do need to change anything around the algorithm. One thing that was very interesting is a patient had an acute episode and the patient injured themselves or something bad happened. They went to the clinic or emergency department. It was taken care of. Now they're coming back. They're reporting additional symptoms, but it's not clinically urgent. So this is actually a very interesting scenario that we found that it's not clinically urgent, but the AI engine indicate that this is urgent. So this is very interesting. This is where Don can help maybe provide a lot more details into that.
Sure. So let me just do just a little commentary before I get into these interesting topics based on what she said. So the first thing, it was 1 year between us building the model and actually going live. So that's how long the process of governance took at this customer. And one of the things that I did notice is that, essentially they didn't really have a governance process. This was the first AI model that they were working through. So they didn't know where to ask permission. Everybody started to get involved, their lawyers, their leadership, that, the board's even been presented this thing. And this is the simplest use case. We're just sorting a list. So they're still going to read every message. They're still going to respond to every message. It was just putting the urgent ones higher up on the list. So it's the safest use case I could possibly imagine, but it still took a year for them to get through because it was their first one. Now, I kept telling them to call over to the Department of Radiology because I bet you they have figured out how to get AI models in there, but that connection never got made. So it was kind of a long process. And part of the process was explaining AI and explaining how accurate this model was. Like, is it good enough for us to use, and how to really clarify that. Okay, so one thing on the overall model, I don't have much more, but for those of you who know machine learning, I'll just give you a few sentences on this. First of all, they wanted an on-prem model, so they didn't want to send anything off to a cloud provider because it was PHI, and some cloud providers are good with PHI, but they were nervous about that whole thing. So we used a derivative of BERT. BERT stands for something. The T is the transformer. That's the style of bidirectional encoded relational transformer. But you saw on the slide today, there was a picture of that Sesame character. The speaker never told you why he had a Sesame character on a slide, but it's BERT. Those were the original slides. So we're now at an AUC of 95, and we're using a model called Albert. So this is a kind of subsequent version of this, and it has been fine-tuned based on unlabeled messages. They gave me a few weeks of unlabeled messages. And by fine-tune, you basically use those messages to teach it to predict the next word. So it was getting used to their patient messages, not just the general knowledge of the English language. And then it was using supervised learning. It was basically taught to recognize urgency based on these 1,000 labeled images. So that's basically the way it was done. We're up to 95% AUC. So one question was, is 95% a good AUC? And what does AUC mean anyway? And so this was a very tough process of explaining AI. And I feel like I'm an above average explainer of things, but it was just really a long process. I eventually would say things like, just think of it as accuracy. It's 95% accurate. So it's not perfect, but it's not so bad. But they wanted more on this topic. So one of the things we did, which Chi talked about, is we compared it to humans. Now, a lot of supervised learning tasks, it's a black and white label. Did the patient get readmitted or not? Did they show up for their appointment or not? Whether something is urgent or not, two people disagree on this point. And so the level of disagreement between physicians, in this case, equaled the level of disagreement between the model and any of the one physicians. So we use kind of this human process to say it's about as accurate as two doctors trying to agree on whether a message is urgent. So that was an approach that we used. And that's not so bad in retrospect. I think in some cases we're going to look at measuring how accurate a model needs to have by saying, well, what about the humans in the process right now? What is our baseline? And can this model be better? Okay, so a couple interesting topics that I thought I'd touch on before we get to our second use case. So one was the concept of the threshold. The second was concept of a story arc. And the third is chest pain, just a small story about chest pain. So threshold, fortunately, I really want to be a math teacher, so I'm going to bring you through a little bit of math on this. But unfortunately, a machine learning model will not tell you whether something is urgent or not. It'll just give you, for a binary metric like this, it'll just give you the probability that this message is urgent. So you're left with the agonizing decision of where to put the threshold, basically. And everything above that we'll label as urgent, and everything below we'll label that as non-urgent. So this is a discussion you need to have with the clinical and business leaderships, and therefore the burden is to explain what a threshold actually is. So let me just tell you how I explained it in case you have this burden at your organizations at some point in the future. So I basically said, all of our messages. I've taken away the text column, but this is the messages, their IDs, and this is the probability of being urgent. This is fictional. I just have them all kind of lined up. If the model didn't work and 10% of messages were urgent, where would those messages be on this list? So they'd be kind of randomly spread out. Every 10th message would be urgent, okay? So it would look like this. Maybe it's hard to read, but every 10th message, I have the label column now, would be true, would be an urgent. So if the machine learning model is working, what would happen? The urgent messages would bubble up to the top, okay, if you sort this by probability. Okay, so that's kind of the way to think about it. So in their case, in the set-aside data set, there were so the data set that I'm about to show you, they're 6.8% urgent, which is a little bit higher than average, but the reason is we trained on more urgents than the average just to get the model to learn about urgency. So what that means is every 15th message would be urgent if the model wasn't working. So that's kind of what it looks like, every 15th message. Here's another way to look at it. I'm just showing the urgence. You can see where it is in the list, 15, 30, 45, etc. So in their data, this is what it looked like. It was in the 13th, and this is 133, list of 133. The 13th, 23rd, 40th, 66th, 98th. So that's kind of the model not working case. It's actually every 14th message. And what I told the customers, this is what you do today. So you read these messages in FIFO order. So every 14th message you're going to get is an urgent message. So if the model can bubble up some of these to the top, then you're going to have a better outcome for your patients. Okay, and this is what the model does. So picture a list of 133. The urgents are at 1, 2, 4, 7, 9, 12, 17, 18, and 26. There are 9, I think there are 9 urgents in the set-aside data set. Okay? So this is good. It's not one every 14th message. By the time you get to the 26th message, they're all there. Okay? So this ability to bubble to the top is what AUC is. There's more complicated math behind that, but that's it. It's ability to sort stuff to the top. The other thing that you should notice is the model is not perfect, right? The third message is not actually an urgent message. The fourth one is not an urgent message. So it's not perfect, but it does get things to the top of the list. So when selecting a threshold, one of the things you could think about is the extremes. So the extremes might be, first of all, maybe it's intuitive, but just to state it out loud. So it's really a balance between missing urgents and having false positives. So if you do the bar down here, you catch all the urgents. And if you do the bar up here, then you have no false positives, but you miss a lot of urgents. So it's really that balance of kind of false positives and catching everything. Now, one of the things that we did discover, so what we actually, let me just tell you what we did, and then I'll tell you the feedback on it. So we looked at two strategies. One is to match the actual ratio of messages. So in this group, 6.8% of messages were urgent, the top 9. So we picked a threshold that would catch the top 9, 0.32. So that means that we're selecting about the percentage of messages that are urgent and picking that as the threshold. The other concept we looked at was to target a false positive ratio. So we don't want to bother the contact center specialist with non-urgent messages, at least not too many. So you target a false positive ratio. And one of the other health systems that we are aware of that did a project like this, they picked a false positive of 33%, basically. So that's another way to pick it. In the end, we chose the first message, which is basically to match the amount of urgence in the data set. And the feedback that we got is that users grumble that the system is flagging messages that are not urgent. They grumble a little bit. However, they do say, like Chi mentioned, that these aren't bad patients to call and at least get to their message sooner. Maybe they're not urgent, but it's not like a, hi doc, have a nice day message. So it's kind of, more important. So they kind of they recognize that they're false positives. They don't use those terms, but they recognize that there shouldn't be an asterisk, is the way they phrase it. But they're not bad patients to call up and address. They also say the model hasn't missed any true urgents, which I found surprising because the math doesn't work out in that. We should be missing some urgents based on our labeled data, but not according to these folks. So I said, well, if we're not missing any urgents and people are complaining about false positives, let's crank the threshold higher. So I say this on every call, as Chi knows, and they say no. So it's a little bit like Dr. Lin said a couple days ago. Management wants the bar to be low enough that we catch all. And so they said, look, we'll put up with the grumbling of our users, but as base state, we want to make sure our patients are taken care of, so we want the bar to be a little bit lower. So that's just some of the discussions you have about threshold, but it is one of the key decisions you run into in discussing with them. And it's also a way to explain that ML isn't perfect and kind of talk about how good it is. Okay, two other quick things. One is we found that the model, in our biweekly reviews, we found the model wasn't good with the story arc. So imagine a message saying, things are bad, almost died, got hit by a car, shot myself in the head accidentally, blah, blah, blah. But, I went to the ED and everything's fine now. Can I get a follow-up appointment? So the model was looking at this going, oh my God, this guy shot himself and blah, blah, blah. And so is marking these things as urgent. So it wasn't really recognizing a bit of a story in the message. So one of the things we did was we found 50 messages that had this story arc, and we trained the model on those messages, and that seems to, or added those messages into the training set, and that seems to have worked. My other bonus idea is to maybe train the model just on the second half of the message, or have a separate model on the second half and weight that along with the whole message, or something like that. But so far, this seems to have worked. But this is one of the fun things we've gotten into. And the last one is these folks are trained to look for the words chest pain. If any patient says chest pain, it's urgent. And I always had this fear that this model is going to miss something with chest pain in it, because the model, it has labeled data, but it wasn't specifically taught about chest pain. So we just added a straight string search into the model because we just didn't want this to fail, because users could easily, and management can easily lose faith in your model by one case of chest pain that the model didn't find. So this is a hybrid model. It has a very sophisticated ML part, and then it looks for the word chest pain. And either way, it becomes urgent. So sometimes you have to do little simple things to just make sure that you build trust in that model. So that's that. So it's a story in progress, but so far the customer likes it, is doing good for the community, and we'll continue to evolve it. Okay.
Yeah. So I'll just open this use case real quick. The clinical quality, absolutely everybody says it's important, but you can read the slide here. It's just reporting is expensive. So I have some data points based on the publicly reported information. Johns Hopkins every year spends about $5 million on quality reporting. And what's interesting, organization already trying to look at AI to facilitate these chart reviews. So UPMC, they have much better efficiency when was using the AI to do this. So I was thinking, wow, maybe we should work on this as well. Guess what? Baystate came to us for Mass Health. They had to report on depression screening follow-up. It's one of those measures that was added, and they had to figure out how to do this efficiently. Depression screening follow-up, just in a nutshell, just the patient had a positive screening, they need to follow up. So I'll have Alex explain more.
Thank you. So I was not involved in the patient portal messaging project. So then Don came out of that, and he's my boss, but he said, you know what, you're very impatient. You should do the next one because this will be a great learning opportunity for you. And I thought I'd spend a couple weeks coding, fine-tuning the ML model on this use case, and we haven't even gotten there yet. So let me talk you through what we're doing here. But basically the problem is, so let's say you have an elevated depression screening. You need to then be able to prove that you had a documented follow-up for that patient within 30 days. And that follow-up can have a variety of, things, right? So you were referred to behavioral health, or you had another screening that was negative, or you were put on a medication, whatever that may be. But you have to prove that that happened. And you also can't have had a pre-existing diagnosis of any mental health condition, right? So the first thing we did as we looked at this and kind of had them talk us through it was, well, there's actually two possible models we could build. One that just looks at exclusion. So if you give us records with an elevated depression screening, we can filter out the ones that already had a pre-existing condition in the record, right? And then for the ones that didn't, we can look at what's the follow-up documented. So the way they do this now is a very manual process. And basically what we've done the last couple of weeks is we sat with them and had us walk us through it. And it's been painful. And first of all, it really proves how important it is to solve this problem, but it makes you ask the right questions. So what they do is each year, they select 300 patients randomly from the payer side. And then on the clinical system, they need to wade through those 300 and kind of look at, okay, did they have an elevated screening? Did they have a pre-existing condition? Did they have the documented follow-up, right? So as we've been going through this is kind of the step-by-step, right? And they walk us through it, and then they, and it's not their fault, but it's interesting to see them pick a record, open up the chart, and look for these things, right? So first they identify, okay, what date was that PHQ-9 taken on? And we asked them a lot of questions like, okay, if they have had several, do we take the latest or the most recent? If they had 2 in a year, which one do we take? Is it a calendar year or a rolling year? Like, what are we looking at? Because we need all these details kind of answered before we can kind of cut the record down. And then they're looking at, was there a documented follow-up? And you'd be surprised how they manually read the chart to hunt down this follow-up. In some cases, it's easy. If you were put on a medication within a certain time frame, then it might be in an unstructured note. We literally had cases, I think the first case we looked at, the physician documented it in a phone message. So it was a message that said, I called the patient, talked to them about, I think it was behavioral health follow-up, and the patient declined. But even if they declined, that counts as a documented follow-up. But so we had to decide, is that an edge case? Do we need to also look at the phone messages? Where do we get that data from, right? So it's a lot of questions you're asking. But basically the idea for us is they'll give us, a set of 70, did we say 70? 70 records, because to them model 2 is more important, looking for the documented follow-up. So give us 70 records where they didn't have a pre-existing condition, they had an elevated PHQ-9, and now we're trained in a model to find if there was a documented follow-up. And we're going to ignore the phone messages because apparently that's an edge case, and it was dumb luck that the first one we looked at fell into that. And then we can categorize them into, was there a documented follow-up or not? Right? Are they compliant or not? But again, we haven't even gotten to this stage yet. Now they're looking at this. This customer is actually, for those of you who don't know them, they're a HealthShare customer. They have a Cerner system. So right now all the work is done in Cerner to kind of chart chase through that and find this information. Since we don't need the phone messages from Cerner, we're going to look at the actual record from HealthShare to do this, and we'll cut the entire patient chart down, basically, to look at that PHQ-9, cut out everything before it, and then look forward for the 30 days or 2 days, wherever the documented follow-up is supposed to be, and train the model on that. So when did we start, Chi? Do you remember?
The first time it was mentioned was about a year ago also, and but later on they're like, okay, should we do alternatives? But later on we started doing the audits about 3 months ago.
Yeah, I think we've worked on this for 3 months now. So we have not even trained the model yet, but I think we and they, as we're going through this process of just watching the users do this, are getting a good understanding of how do we actually label and train the algorithm, before we then operationalize it. So that's where we're at right now, Chi.
Yeah, I'll just close this out by talking about the importance of chart review. It's actually everywhere in many cases in the health systems. And this is an example of it was a paper. It was published by several folks from the Brigham and MIT, and really it's a use case talk about. They want to extract all these concepts on the right. Uterine atony and uterine ruptures. This is related to postpartum hemorrhagic, the type of cases that they want to look at these concepts. So instead of by manually going through the chart on the left, which is discharge summary, they're basically using the large language model to ask basically using ChatGPT to say, okay, does the patient have uterine atony? And this is how they get the concepts. So you can see that these are the zero-shot extraction. That's what's being used. And what later on will be useful is that now you have structured data. You can build prediction models and so on and so forth. So it's just one way of extracting targeted concepts, and then you can use the traditional tabular AI to build models about the predictions, whether the patient is going to have hemorrhage or not. It's one useful use case for the prediction model development. The second example is oncology related to cancer registry data upload. So in this case, it's also a fairly new study that the UCSF did. It's also using the zero-shot approach. Now, what you're seeing here are the cancer-related information, including TNM staging, the metastasis and type of procedures and so on and so forth. All these are being the target concepts. Everybody, you'll see that a lot of clinicians or researchers in the hospital are busy extracting data from the chart to fulfill this requirement. Now, the blue bar is a blue score, which is a sequence. It's a measurement of the output generates these set of words in certain sequence, how it overlaps with the reference annotation. So the longer the bar is, the better it is. So it's simply comparing different different large language models. But it's just validation of the use case is very meaningful. If you have registries and oncology-wise, and this is a very good one. So in summary, I'll just really these 2 points that you saw earlier. It can definitely enhance patient engagement. That was a good example. Quality improvement. It's not just about reporting. The clinician, clinical leader really want to improve quality, which means I don't want to just do retrospective analysis. I want to do monthly, identify those patients. So it's all about improvement, not like just reporting. But you also saw that, just like Paul Grabshire talked about earlier this morning, organization. We had to think about workflow, governance, lots of time, spend a lot of time educating them and communicating with them. So it takes a long time. And even the earlier part, you saw that depression screening follow-up, we spend a lot of time trying to even understand what they're trying to do, right? They don't come to you and say, this is the business case. No, it's not as clear cut. You have to spend time understanding them. Make sure you fill out the survey. I was told, remind you every time. So that's our, that's it, our presentation. Thank you very much.